Guys, I hate this. Aspen, go ahead and tell me if we're presenting. I can't see it on my system.
Yes, yes,
We
Doc.
are?
Yes, we are.
Okay. I'm going to go ahead and present. We've got, welcome today. We're excited to have a guest. His name is Chuck. I'm having some computer problems. I'm hoping that we're going to get through some of the challenges this morning. We're going to be talking about LP(a). Chuck's got a very interesting LP(a) story. Because of our challenges with the technology this morning, I'm going to skip through our preliminary information and go straight into the discussion. Oh my goodness. I tell you what, Chuck, you know what's happened? We've got the wrong, Chuck, why don't you just tell us your story? And let me see if I can get my technology set up while we're doing it.
No problem. Well, glad to be here. Hi, everybody. I've been following Dr. Brewer's videos for some time, since the shaky paper days. Well, I don't know if since the shaky paper days, but I've seen a lot of I've gone back and watched a lot of the old stuff, so I've seen a lot of the shaky paper videos. But yeah, great to be here. My story, basically, I do have a family history of some early deaths in the family from heart disease. I never knew my grandfather on my mother's side because he died before I was born. Died at age 52 of a heart attack. Turns out he had a cousin that died at age 44 of a heart attack. And then his father, so that would be my maternal great-grandfather, died at age 54 of a heart attack. So I have a brother a couple years younger than me, and we were always kind of, aware of this. We were aware that there might be a serious genetic predisposition to heart disease in our family. So we tried to live healthy lives. We tried to, exercise, control our weight, eat healthy, not eat fast food, and watch our LDL levels and all that stuff that's recommended. But then a couple years ago, a heart murmur was detected in a physical, and ended up being sent to a cardiologist who wanted to run, thought it'd be a good idea to run a whole bunch of tests on me, echocardiogram and EKG. And he also ran an advanced lipid panel called a Cardio IQ from Quest Diagnostics. And so I'm the kind of person, I like to look over my lab work and kind of, if I see something that says hi, I'll research it. So the Cardio IQ is a great report. It gives you all kinds of, not only standard lipid panel, it's an advanced lipid panel, and it gives you all kinds of particle size information, particle counts, particle size. And another thing that it gives you is something I had never heard of before, called Lipoprotein (a), or abbreviated LP(a). And I'm looking at the category, the line item for that, and I see an H, a bold H next to that. Oh, that's elevated. That means it's elevated. And I looked at my count, and it was 243 nanomoles per liter. The reference range was 75. You're not supposed to be over 75. Over 75 is elevated. So that caught my attention, because I was over 3 times the reference range. So I started researching it, and that's actually how I found Dr. Brewer's channel, because he's got some really good videos out there on LP(a), and some of them are from the shaky paper days, but he covers a lot of the bases with LP(a). I learned a lot from Dr. Brewer. There's a lot of other videos out there. I read a lot of papers, published literature on LP(a), and realized this is a very, very serious issue. It's something where if you have high levels, it can lead to heart attack in your 40s, 50s. In fact, very often when you hear about somebody who has a heart attack in their 40s and 50s, or has chest pains that lead to stents, you'll find upon further investigation that it is Lp(a) as the culprit. And a lot of times it goes unnoticed. Unfortunately, the medical community is kind of oblivious when it comes to knowledge of Lp(a). I don't know, you're probably talking about less than 5% of the doctors in the country that are Lp(a) literate. Dr. Brewer, you probably have a pretty good handle on that. It's a low number.
Go ahead.
And so we also, kind of putting 2 and 2 together, we said, wait a minute. Grandpa died at 52, and it's also highly genetic. It's unlike LDL. LDL you can control with diet and exercise, and then if you can't get it low enough, you can take a statin. But with Lp(a) is different. It's genetic, and there's really diet and exercise have no effect, virtually no effect on it. So that's one of those things where you go, oh my gosh, what can I do? It's highly genetic, which means, if you have it, I have a brother, so we had him tested. I have 2 children, 2 biological children, and I had both of them tested. And I had my parents tested. And it turns out, sure enough, my brother has sky-high levels like me. He's in the 240, 250 nanomole range, just like me. One of my children is totally normal, and one of them has very high levels. She's not as high as me, but she's about 150. And my mom had a level of 200 nanomoles per liter. And so my dad was totally normal, by the way. So you can see, you don't have to be a rocket scientist to figure out, okay, almost certainly it came from my mom. Her dad died at 52 of a heart attack. We're pretty certain that was the cause. And what we did next was, again, I had done a lot of research on it. My cardiologist, he wasn't real knowledgeable about it. He knew some things about it. And I felt like I wanted to, he didn't seem very concerned about it, quite honestly. And I think a lot of times people get that high score, and correct me if I'm wrong, Dr. Brewer, but a lot of times people get that high score and it just goes unnoticed.
It does. It does. You've brought up a whole bunch of things. And as you know, we've got a deck, if I can ever get my technology to work over on this side, which can help explain a little bit about why it's genetic, what proteins are made in your family. It's a variation of the protein that forms LDL, and it's got a thing on it called Kringle repeats. The Kringle repeats look like a little hook hanging off. Now, a lot of folks think that actually makes it sticky, that it hooks to the artery wall. There's another mechanism. Some people, and it could be a little bit of both mechanisms, where it's not really clear which mechanisms actually are having an impact. The protein that forms LDL and the related protein, especially in your family, that forms Lp(a), is very much related to the proteins that form clots. So the question, the potential mechanism there is that that there's some increased clot forming activity. Have your doctors talked to you about either of those?
Yes, there's basically the issues. The 3 major issues with Lp(a) are increased risk of atherosclerosis, increased risk of aortic stenosis, valve calcification, and venal thrombosis. Would that be correct? Say those 3 would be the 3 major risks. And so for me, what we did was I wanted to dig a little deeper and to see what was going on. So in consultation with my cardiologist, we agreed to decided to get a CAC scan done to check the calcification in my coronary arteries. And some people with high levels of Lp(a), and by the way, my level at 243 nanomoles puts me about at the 95th percentile. So that's very high. However, about 20% of the population has an elevated level. So this is very common. And so the CAC scan, it wasn't great. You know, you hope at my age, I was 52 at the time, you hope that you'd get a 0. Most people have a 0 at that age still. And I had a 35, which, you know, it's not the end of the world, but it put me in the 74th percentile. I was hoping, you know, living as healthy as I thought I had been living, I would have been lower than that. But it is what it is. It shows, you know, some early signs. It's indicative or suggestive of some early signs of heart disease. And so, yeah, I don't know if you want to go to the slides, Dr. Brewer, if I should just keep going with what we did. And
well, why don't we're getting a little bit of that echo again. Why don't we let me cover a little bit of slides, some of the science to help people get a picture of what you're talking about. So the first question is, what is Lp(a)? It's a large sticky protein made by the liver and found in blood plasma. It's a variation of the protein that forms LDL. It consists of an LDL-like particle, ApoB, but again, like I said before, it's got this little patch of Velcro. It's called, each of these is a Kringle repeat. And as I said before, there are a couple of mechanisms. One is that this Kringle repeat makes it sticky. Another is that this something about this part of the protein actually triggers clot formation. Any comments about your own story specific to these two issues, Chuck?
No, not really. That's nothing specific.
Okay. So as you mentioned, most docs don't know this. They don't. And you asked me what portion of docs, and your estimate was like 5%. I would think that's a generous estimate. I mean, even among primary care docs who need to be the folks that are aware of things, may not know how to treat everything, but at least can find stuff and can triage it to the correct place. I don't think even 5%. That means 1 out of 20.
That's probably more like cardiology. As far as cardiologists, it might be more like 5%.
I think you're right. Now, that would be my guess. It's probably closer to 1 out of 20 among the cardiology community. But as you know, the rest of the story on this too, and it's like, well, we don't know anything that we can do to fix it. So just tell them to do everything else and we won't even look. And that's why most primary care docs, I mean, even more primary care docs, are just not aware of it, and patients aren't aware of it. Let's talk for a minute about some of the risks. So any significant elevation gives you 2 to 4 times the increased risk for cardiovascular disease. Most people, you talked about a range, so most people have a range 5 to 29 in a milligrams per deciliter, and that's 13 to 73 nanomoles per liter. Now, the risk, depending on what level of risk you're talking about, starts at that 30 milligrams per deciliter or 75 nanomoles per liter. And it starts rising much more steeply when you get about just a little bit less than double that, 50 milligrams per deciliter and 125 nanomoles per liter. Now let's go back with those numbers in front of us, and you tell us a little bit more about your numbers. I think you were saying you got up to a couple of 100 nanomoles. Is that correct?
Yeah, my level was 243 nanomoles, and you mentioned that it's also measured in milligrams per deciliter. It's really important to understand what you're looking at. And a lot of people, even doctors I've talked to, a lot of them will get this wrong. Yeah. And it's amazing. It's unfortunate that there's not a uniform, measurement used. The conversion factor is approximately 2.5 to 1. So It's not an exact figure. It varies person by person, but if you take your milligrams per deciliter number, multiply it by 2.5, that would give you an approximation of your nanomoles per liter, and you can go backwards. If you're in nanomoles, you could go backwards to look at your milligrams per deciliter by dividing by 2.5, which is important if you're looking at research and trying to understand, if they're talking about milligrams per deciliter and you've got a measurement for yourself that you're looking at nanomoles per liter, you might want to do that little conversion to understand relatively where you're at. But yeah, so again, 243 at baseline, and that was on a statin. So basically, you want me to go on with what I did then to
Sure.
get my result? Okay, so there's a slide. There it is. So there's a slide. This was a study published in 2007 by Dr. Semikas and Florian Cronenberg and several others. And it showed many things. One of the things they looked at was Framingham risk factors graphed against Lp(a) tertiles. And really interesting finding. To me, this was one of the studies I came across early on in my research, was that if you can control your Framingham risk factors, which are, your weight, your BMI, your blood pressure, your LDL level, whether you smoke or not, whether you have obesity or not, or whether you have diabetes or not. And if you control those, and if you can get, all of what this graph and what this study suggests, that if you achieve near optimal level for your Framingham risk factors, you can bring your even if you have elevated Lp(a), you can bring your hazard ratio or your risk, pretty close to the normal population. Might be a little different for someone like me. This is top tertile. So you're talking about people at 23 milligrams per deciliter and up. I'm 4 times that. So I might have a higher, that might not be enough to just control the Framingham risk factors for somebody like me that's up in the top 5 percentile. But what it suggests to me is that, my gosh, and this is why I think it's so important for everybody to know. So, like Dr. Brewer, you mentioned that a lot of doctors will have this attitude, well, there's nothing you can do about it, so why measure it? Why test for it? Well, this is a great reason why. If you know that you have something, if you have an Lp(a) is an independent risk factor. It's been fully established, settled science that is an independent risk factor. If you know that you have something that might give you 3 or 4 times risk of a normal person, that might be something that would be highly motivating for somebody to lose that extra 25 pounds or 15 pounds, because there are things that you can do, for most people that have elevated Lp(a), there probably are things you can do in terms of lifestyle or maybe therapeutics that could bring your risk. Again, this is based on, what the studies seem to suggest. You could probably bring your risk, let's just say you could bring your risk down substantially, and possibly close to that of a normal person. So what I did, I decided that I was going to, lose 25 pounds to try to get to BMI. My target BMI was 24, and I was able to achieve that. I had sort of borderline hypertension. My high end of my blood pressure, I was about 135/90. So wonderful thing about losing weight is it just hits so many of the Framingham risk factors. Yeah. I'm now in the target for the BMI. My blood pressure, when I lost the weight, my blood pressure came down. I'm now 115/75, my blood pressure. So that's optimal. Yeah. I also, the next part of the study was I had to go on something to lower my LDL, but I am now in range, ideal range for LDL. And let's see, what other risk factors? Of course, pre-diabetes. At the time they did all that blood work, one other thing they found was that I had a fasting blood glucose of 108, which is by definition pre-diabetic. So, and that's Dr. Brewer has some, as most of you I'm sure know, has some great videos on, you know, reversing insulin resistance. And I watched many of those and learned a great deal, and cut out all of my processed carbohydrates. I eat basically a whole foods plant-based diet, except I do eat fatty fish rich in omega-3s. So I was able to actually, you know, my blood work would now suggest that I've reversed my prediabetes. My fasting blood glucose has gone from 108 to 93, and my A1C is now 5.0%.
So adjusting your volume, I think we're getting that echo back. So do you mind sharing with the group how old you are and how old some of your other family members were when they had events?
Is that better?
It is better, yes.
Look, I think you're on mute.
Oh, you can't hear me? Okay.
So
go ahead.
Yeah. So basically, just in controlling the you know, the other risk factors, my goal was to get all of them within range. And then the other part of this that's kind of interesting, a lot of folks are not aware, I was on a statin before all of this blood work was done and the discovery of the Lp(a). And it turns out statins, for most people, they will actually raise your Lp(a). For some people, it's 5 or 10%, but for some people, it's as much as 30 or 40%. It could be a drastic increase. So in consultation with my doctor, we decided, because we had a target LDL, we needed to get my LDL down, and we also wanted to get my Lp(a) down. We decided that the appropriate therapeutic for me would be a PCSK9 inhibitor, and in this case, Repatha, which works like similar to a statin in terms of its effect on LDL. It actually, correct me if I'm wrong, Dr. Brewer, but I believe it has a larger impact on LDL lowering than statin generally.
It does.
And a lot of people who don't tolerate statins, a lot of in consultation with their doctors, will go on PCSK9 if they are not able to get their LDL to target range, or if they're not tolerating the statins, it's used for that. But another really nice thing is that it happens to lower Lp(a) as well. So, but before I went on PCSK9, we washed out the statin. So I went completely off the statin for 3 months, took another baseline of my Lp(a). And interesting, my Lp(a) went down 5% from that. So now it's a little movement, but I'll take it. It's something. The next step, I was involved in, well, there is some anecdotal research out there, some anecdotal evidence that omega-3s might lower Lp(a) in some people. And so I went in consultation with my doctor. I went on relatively high dose of omega-3s, fish oil via fish oil supplement. We targeted a level of 4,000 milligrams of EPA, and checked my levels again, and it actually lowered it another 5%. So we had a little bit of movement then. Pretty soon after that, I did go on the PCSK9 inhibitor. That's where I got the really big effect. PCSK9 inhibitor actually dropped my Lp(a) another 40%. So I'm now at 131 nanomoles per liter, with most of the credit going to PCSK9 inhibitor, which that's still high. You know, if 75 nanomoles is the target range, being under that, I'm still high, but I'm 70% elevated instead of being 330% elevated. And based on the research done, it would seem that I would be at a significantly lower risk or hazard ratio, as you would say, based on my new levels of Lp(a).
That's very helpful. Let me let me talk for a few minutes about some of the things that you've raised.
I think.
Can you hear me? So the first was the risk or hazards ratio. Yes. In fact, if we could go back and talk a little bit about the image here that we discussed a few minutes ago. This is risk on the left-hand side. For those of you who are confused, it takes a little bit to understand the concepts and what this is actually telling us. This is HR stands for hazards ratio, and it's a measurement of risk. If the hazards ratio is 1, it's the experimental group or the group with Lp(a) has the same risk as the group without it. If it's 2, this group has double the risk. If it's 3, it's triple the risk. 4 and 5 times the risk. So here's the other thing to think about. This is levels of Lp(a). Blue is a level of Lp(a), less than 6.9 up to 6.9. Green is 6.9 to 23.8, and pink is 23.8 and above. Now, so as Chuck mentioned, his was like 250, so 10 times that 23.8. As we've also mentioned, the vast majority of people are in these lower ranges. Let's just call Chuck's range more like a world-class range. With folks that have these smaller numbers, 23.8 up to 50, 70, numbers like that, this is what you tend to see. And that's most of the people even in this group, this pink group, had those kind of numbers, unless I'm mistaken. Chuck, if I am, please interrupt and let me know.
Just one point, you were comparing, remember, I'm in nanomoles per liter. First of all, I apologize if I was talking over you in that last segment. I realized I had you muted. So
that's okay.
I thought something was wrong with the sound on your end, but I accidentally had you guys muted. So I apologize if our communication seemed a little disjointed.
Clear us up on the units.
But yeah, the units. So I'm in nanomoles per liter, and this study did it in milligrams per deciliter. So
okay.
My level is about 4 times the beginning point of the top level here, being 23.
Okay. So 4 times, just 4 times rather than 10 times. Anyway, significant increase. And again, I still say that that would put you in more of a world-class number. If you look at these units, milligrams per deciliter, what is it? Is it something like half or more are at like 30? And then once you get to 40, you get, gosh, another major portion of folks. So it's a skewed curve, and the vast majority of people are going to be, like you said, much, much lower than you. And here's what happens. Now, what happens is if you start managing your blood pressure, your insulin resistance, other risk factors, smoking, you start getting down to these we're talking about the Framingham, the classic risk factors. Once you start managing those, very significant risk comes back down to very manageable risk or negligible risk. That leaves, again, those folks that have, again, 100, 200. We've had a couple of people on the show. Joe Riley, I think, said he had like 700 or 800. And he did share with us. He had aortic valve calcification. You and I talked about aortic valve before the show. We can bring that up in a few minutes. But as you said, the aortic valve business is something that you're going to see with people that have other genetic risk factors and or people like you that have world-class problems in terms of Lp(a). So it gets back to the point, and I'll repeat this often. I repeated this with you, but prior to the discussion, and that is if you manage all of your other risk factors, you do tend to manage LP little a. And you were very gentle, perhaps overly gentle with me to say, what you should have said was, hey, doc, you know, I'm a poster boy for world-class levels, and we need more than that. Thank you for bringing that up. And I think I wanted to bring that up for the audience as well. Again, I'll say multiple times, it's the reason that most docs have ignored it is, number one, we didn't have a treatment for it. And number two, it had to do with managing all the other risk factors. I think maybe I've butchered that point up trying to hammer it home. Do you have any clarification for me, Chuck?
No, I think that's very true. You know, people, because that's the big question. You know, again, going back to a lot of doctors saying, don't test for it, there's nothing you can do. Well, there is a lot you can do. And controlling your risk factors, we sometimes call those the Framingham risk factors, but controlling your cardiovascular disease risk factors, it's important for everybody to do that. But because Lp(a) is an independent risk factor, it's extremely important for people that have elevated Lp(a). I mean, obviously, you're going to get some people in the population that they just say, "Look, give me a pill. I don't want to change my lifestyle, and you know, see what the pill can do for me." But for those folks that are motivated to try to do what they can to minimize their risk, there are a lot of things you can do. And I mean, the thing that I would want to emphasize, where you get so much bang for the buck in lowering your risk of Lp(a), would be bringing your weight into the optimal range. And that, I think you would probably concur, Dr. Brewer, that to control insulin resistance, and they're overlapping, obviously, because controlling insulin resistance, you get a lot of bang for the buck there. But when you bring your weight down, you improve your insulin sensitivity, you improve your generally, most people improve their LDL profile. And you also, I would say for most people, you're going to improve your blood pressure. Certainly did for me. So you get this huge, all these benefits by doing that. And of course, you know, things like smoking, you know, please don't smoke. And one thing I'll point out, I said my grandpa died at age 52. Obviously, I found out at age 52, I was still alive. One difference, he wasn't overweight, but he smoked.
Yep.
His dad, who died at age 54, he smoked. So, you know, don't smoke. But if you have world-class Lp(a) and you have one of these other risk factors, if you smoke, you're a ticking time bomb. Am I wrong to say that, Dr. Brewer?
Not at all. Again, that's the point that I've tried to make so many times. Speaking of insulin resistance, let me ask, I don't think you heard me a few minutes ago. What age were your family members again when they had events? 42 and 51? Is that?
We had my maternal grandfather was 52. His father was 54. And then there was a cousin. So the grandfather's cousin was actually 44 when he had an event.
So I can tell you this, in my experience, as you know, you're not the only patient that I have with, again, that, pardon the term, maybe it's overused, world-class Lp(a). I just don't know another term to use for it. Like I've said multiple times, it starts happening at the same age that insulin resistance starts happening. And insulin resistance, by the way, starts happening at the same time that we start having blood pressure problems, and at the same time that we start gaining weight. So again, you tend to not see problems when in our 20s, and you tend to start seeing problems when our other risk factors start piling up on us. But
oh, sorry, go ahead.
As you've said, managing all those other risk factors, being aware of them and dealing with them is not easy. Dealing with insulin resistance is not an easy thing to do. Losing weight's not an easy thing to do until you get the hang of it. But it's very effective at dealing with this risk.
Another thing that you talk about yes, people start having heart attacks when they have elevated Lp(a) in their 40s and 50s, and it certainly correlates when people generally start to develop decent levels of insulin resistance. There's some studies being published showing, and if you talk to people who are in the space of treating Lp(a) patients, like yourself and you listen to Dr. Ronald Krauss. He's a luminary in the lipidology field. He treats a lot of Lp(a) patients. He talks about, and I believe he's published a lot about small, dense LDL particles.
Yep.
And he talks about when you get these patients who, of course, Lp(a) elevation can increase your hazard ratio, 3 to 4 times. He estimates when you get people that have those high levels of Lp(a), and then you combine it with small, dense LDL, you're talking ticking time bomb, maybe 10 times the hazard ratio. And it's all overlapping, because actually what causes high levels of small, dense LDL? High levels of triglycerides. What causes high levels of triglycerides? Insulin resistance and high levels of insulin. Yeah. So you start seeing these studies and you start connecting the dots, and you realize, boy, I better get my insulin resistance under control, because there's so much there's so many independent risk factors that start working together if you don't start controlling the ones that you can control.
Speaking of treatments and risk factors, you didn't mention niacin. Did you ever try that?
Niacin? I take that back. About 10 years ago, I was on niacin for a couple years to try to lower my LDL. And then a doctor told me that a study came out that showed that it doesn't do any good. And so, and I think we both know that probably he was reading either HP Thrive or Aim High,
right,
on that. And I'm not currently on niacin, but that's an interesting topic. Do you want to talk about that? Or
I've had several people. Most of my folks with Lp(a) do take it, and I've had some pretty good results with it. It's certainly something that I would recommend consideration if someone has it. I think the biggest issue that you and I talked about is just the failure of the medical community, including the labs, to screen for this problem.
Now, lack of awareness.
Right. And you coming on board as a patient is very, very helpful to help people begin to be aware and start taking a look. Aspen, if you could, I'd like to show this 1-minute video from another patient who shared his story about his heart attack associated with Lp(a).
Now, the first thing would come to a mind, one would guess, a fitness expert has a heart attack?
Mm-hmm. Yeah.
How?
Yeah, I mean...
any family history?
It turns out, after going to some of the best doctors that I could get, Dr. Oz hooked me up with some really amazing people. I found that I had this genetic disorder called Lipoprotein A. And my mother had died of a heart attack, but she died at 70. So it wasn't like a big red flag for anyone thinking that it would be genetics.
How old are you?
I'm now 52. So I had the heart attack when I was 51.
I had mine when I was 53. But I had a right side heart attack.
Yeah.
So I didn't really have, my pain was, I never had chest pain. I never had.
Yeah, it's like people, I've learned so much about heart attacks now.
Yeah, don't we?
And it's all about, did I feel nauseous, dizzy, all these, I mean, my heart attack just came out of nowhere and took me down.
And do you find, like I did, you become suddenly extraordinarily interested in the heart? You learn about the heart. You read about the heart. I
read about it and continue. I'm fascinated by it because, I mean, I just kept thinking about this muscle in my body that's been taking care of me for such a long time. Just decided to
Not.
just stop. I mean, people have asked so much about my recovery physically, but the mental recovery is a big challenge.
So Chuck, again, thank you for sharing your story. If you're ready, I'll go into the question and answer session.
Just one more point that I would want to throw out there. You know, we've emphasized the importance of people getting tested, and that everybody should get tested. The European Society of Cardiology, or ESC, in 2019 recommended that everybody be tested for Lp(a). We are honestly a little, in the US, we're a little behind Europe as far as Lp(a) awareness, but really that everybody should get tested, and especially if you have a family member who's had a relatively young heart attack or heart event. And another reason, not only because there are certain things you can do in terms of lifestyle, and you know, perhaps there's some therapeutics that might help some. On the horizon, there's some very promising looking therapeutics, and we're talking about things that will reduce Lp(a), you know, consistently in the 80% range. And there's, you know, probably we're talking about by 2005, there's going to be maybe one and maybe two or three approved. So that's another reason to be aware whether you have high Lp(a).
A couple more, if you could adjust the volume. So regarding the Europeans, yeah, I agree with them. The other thing I would tell you about the European Standards Committee, they also recommend use of niacin. So again, they have some significant differences with the Americans, and I do both. I screen everybody. You know, if you look in most of the American groups, they start saying, well, people that have a family history of early problems, people that have a family history of Lp(a), just screen everybody. It's not that big of a deal, and you just need to know. So again, I would agree with you. I think the Europeans are ahead of us in several places. That one, niacin, and a couple of others.
Did we want to quickly, I could do my, you know, with Repatha or with PCSK9, you generally inject it twice a month. You want to.
Oh, that's right. I forgot. You were going to go ahead and do an injection for us. Yeah.
So it sounded, you know, at first when I found out from my doctor that it's an injection twice a month, it didn't sound, you know, something I would really be wanting to do. And it turns out it's just so simple. I can't even tell you how easy and painless it is. If you've ever pricked your finger, you know, for a blood test or to check your blood sugar, I would say it's less painful than that. Your fingers are pretty sensitive, and when you're kind of injecting it into places where you've got some body fat, and it tends to, you can barely feel it at all. So anyway, I'll do my injection. It's time for my twice monthly injection anyway. So it comes in a box like so, and you get 2 of them per box, and they look like this. Let's see.
We can see it.
Okay. And you clean the spot. They're really good. It comes with this card that tells you, you know, all the steps and where you get it prescribed you. You know, for me, the nurse kind of walked me through my first injection, and that's probably a good idea. And they make it kind of really foolproof with these cards and so forth. And you've got a couple different options. I like injecting mine in the stomach. So I'll just show everybody how easy it is. Okay, so you take, here's the injector, whatever you call it, the device. You take out this red thing in the top. I've already cleaned the spot that I'm going to inject with alcohol. So I'm going to put this, basically you pinch an inch, and then you put this yellow part down on there, hold it flush, and I'm going to push the button at the top and then wait for a click. That's it. And really hardly felt a thing. I mean, like I said, it's less painful than the finger pricks, and that's twice a month. It's that simple.
Thank you so much for showing that. I think we'll get a huge increase in our viewership after having taken a look at that 6-pack of yours. Appreciate that.
1 pack.
But as we had discussed, that's again a huge service because, as you mentioned, the PCSK9s like Repatha, the most popular one, are important medications. They're very expensive. You tend to see them for people with very significant levels of familial hypercholesterolemia, and as you've mentioned, folks with Lp(a). And it's an injection, a self-injection, and it's like, that really is scary for a lot of people to wrap their head around it. It's not that bad, is it?
No, it's really can hardly feel it at all. It's quite simple. Yeah, not bad at all.
So Chuck, again, I can't thank you enough for sharing your story. It's so different to hear some academic geeky guy, doc, standing up, showing slides and showing shaky paper, and like today, just continuing to struggle with technology. But to hear a real human story from a real human who's had the problem is just a whole different ballgame.
Well, it's been an honor, and it's been my pleasure to be here and to share my story. Thank you for having me.
Thank you. And I think we're going to have some questions that we'll probably need you to respond to. So if you don't mind sticking around, we would appreciate it.
Happy to.
Okay. So John Tocho, good morning. Still waiting for vaccine. Still will not be vaccinating my mother-in-law, senior residents, until February 15th. Yep, some of the states are just really slow. I think Minnesota is one of them. Am I taking, or am I, what do I think about ivermectin? I've been taking prophylactic ivermectin. I've given it to a lot of patients. What's an interesting thing, I actually made people aware on the videos, and I didn't get a lot of takers. You know how people are on YouTube. They heard some of the negative comment. Anyhow, people just tend to take things through their filter. I'll just leave it at that. But no, John, I've provided that to quite a few people. Good morning, Aunt Martha. James West's Aunt Martha. Good morning, Bambi. Good to hear from you. Bob Weiss, good morning from Florida. Bob is usually coming from the North Georgia mountains. Very low carb, less than 55, BMI 22.5, excellent. Walks 4.5 miles a day, 15 carb meals, no plaque, very good. Supplements, what can I use to tell me how my pancreas is performing? Insulin survey, absolutely an insulin survey. That's, you know, we mentioned why not go ahead and do Lp(a) screening on everybody. We do insulin survey on everybody as well. I strongly, strongly recommend it. Okay. Bart, good morning. Another great topic. Gail 716, looking forward to this topic. Appreciate having you with us, and hope that and my stumbling around the technology didn't make it too confusing. Again, had a great individual person tell his great individual story. CoQ10, if you don't take statins, you could. A CoQ10 is a fairly general type of support for the mitochondria. The statins tend to stress the mitochondria a little bit. That's why we push for CoQ10. But the reality is, I've done a couple of videos on it. When you look at the science behind impact of CoQ10, it's impossible. And until there's some sort of scientific revolution or technology revolution in that space, it will always be impossible to tell exactly what CoQ10 is doing. I do take it, by the way, and I do recommend it, especially if you're taking statins. Good morning, James. James and I talked about whether or not James should join us for today, and you know, maybe he should have. When I don't know if you noticed, Chuck, but I actually dropped off for a few minutes while you were talking. But again, hopefully my new computer will fix some of this stuff. But you did a great job. Vapor King looks fine. Good audio on his end. Wow. Okay, is that bald guy Joe Rogan? You ever get that, Chuck?
A little bit, yeah, a couple times. I always get people that think they recognize me.
I can see how they would ask, especially on YouTube. I hope you brought your defenses with you. You obviously did if you're willing to show us your belly this morning. That was great. Martha Wright, James is Martha. If a patient does not have family members who have died early due to heart attack, should the patient forego the Lp(a) testing? Absolutely not. You need to know. That's sort of like saying if most of your family has lived a long time, should you get insulin survey screening? Absolutely. You should get Lp(a) and insulin survey screening for everybody. And I would recommend both, at least yearly. Kirk Wallach, wasn't Linus Pauling the first one to blame Lp(a)? Any comments on that, Chuck?
He did, yes. I don't know if he was the first, but he certainly mentioned it. He had some theories, I believe. I don't know how well it's been supported about vitamin C. He has got a lot of theories about vitamin C, and
oh yeah,
I think some of his stuff might be a little bit getting into the realms of maybe not real well supported, but some maybe is. And some people have said to me anecdotally that, well, according to Linus Pauling or some of the research he did, I don't know if this is correct or not, but that if you just take a lot of vitamin C, you'll be fine if you have high Lp(a). And I don't think there's any research supporting that.
Yeah, when you look at the Pauling theory, it makes a lot of sense. The problem is, as you said, once you start focusing on the actual scientific evidence, it starts to thin out pretty quickly. Also, as you said, there's a community that really focuses on it. And some of the guys that are really deep into that community, as you said, just drop everything else and take those 1, 2, sometimes up to 7 grams of vitamin C per day. I don't think that's the best thing to do. You know, I first and foremost, I would not ignore insulin resistance. And unfortunately, over 90% of us are doing just that. So, greetings from the UK. Greetings to you, Bruce. Randy Halverson, is LDL-PA on my blood test the same as what we're talking about? LDL-PA. I've never really seen it labeled that way. Maybe a particle test, especially if it's saying 1673. That's their label for LDL particles. Small particles is small, dense particles. Chuck actually mentioned those later on.
If that was Lp(a), that might be the highest recorded level.
Yeah.
So I kind of doubt it.
I think what he's talking about, and he goes on to say also the small LDL particle measures 292. So I think what he's talking about is his fractionation. And
sounds like LDL particle number, just as a guess.
Correct.
The particle number 1673 would probably be a typical LDL particle number, and then small particle number 292 would kind of be in the range of what you might expect.
So some of you may have heard my presentation on getting fairly deep into HDL, LDL, and the fractionation. The bottom line is most docs don't get cholesterol fractionation. That's a problem. They really should. And what it's showing is the specific particle levels. The large, fluffy LDL particles are probably not dangerous. In fact, they're probably helpful to us. Clearly, the large, fluffy HDL particles are the most effective in terms of improving our health. It's the small, dense LDL particles that cause significant danger to us. And if you're not getting clarity on that with your cholesterol test, you should. Right? That could be a pattern A. Yeah, but it sounds like it is a pattern A with a fairly low LDL small dense. And pattern A is good. Pattern A is a pattern which has more of the larger, fluffier, and less of the small dents. I don't know. Google it. The more I learn, the more. Well, Roscoe, I'm sorry that you got confused. Unfortunately, I tend to stutter and stammer around sometimes and help the process of getting confused. Chuck, I think, did a much better job today. Thanks. I do keto. Never had high LDL until I did it. My dad died of heart disease at 54 and heart attack at 34. You know, Randy, you may want, I would suggest you see somebody that knows a little bit about cholesterol fractionation, knows a little bit about familial hypercholesterolemia, knows a little bit about Lp(a), because when you've got a history of a father dying at age 54 and a heart attack at 34, something else is going on. Those are two of the more common things that happen. I would get checked out specifically for those two things, in addition to that prediabetes. T-bone, Lp(a) 533. He's got some interesting levels there, don't you think?
Yeah, and I'm assuming that's almost certainly in the nanomoles per liter. That would be, 1/10 of 1 percentile if that was milligrams, I think. So.
T-bone. Oh, thank you for the super chat. 533 with PCSK9. Interesting.
That's really high.
It really is really high. Gail 76016. Chuck, what was your LDL prior to this, and how does ApoB levels foretell a high level of Lp(a)? I'll take the second one if you want to take the first.
Yeah, I'll take the first one. Yeah, so my LDL level throughout my life, it's varied quite a bit. I'm one of these people, I'm a high responder when it comes to diet. I've got reports from back when I was in my 30s, when I maybe was eating a few too many cheeseburgers and French fries, where I was close to the FH level. I was about 160, my LDL level. But personally, when I eat, predominantly whole foods, plant-based, a little bit of fish, I can get down to, it really varies a lot, but, in the 90 to 100 range. And when you have high Lp(a), generally they like, your doctor will generally like to have a target, assuming he's Lp(a) literate, would generally have a target quite a bit lower than that. Do you have any comment, Dr. Brewer, about a good LDL target for a person who's at high risk for Lp(a)?
Well, the goal keeps getting lower. It was 120 for a while, then 100, and then 70. But again, I think a lot of us are, and myself included, are less concerned about LDL overall, because there's a lot of people. Have you heard the term lean mass hyperresponder, Chuck?
Yes.
So a lot of people are lean mass hyperresponders. I think there's a significant overlap between the lean mass hyperresponder pool and the FH, familial hypercholesterolemia pool.
By the way, just to kind of follow up with that, on PCSK9 inhibitor, my LDL is down in the 50s range. So it's certainly below target.
So just a couple of quick definitions. FH, familial hypercholesterolemia. It's people that tend to have, Chuck mentioned that he was getting close to that FH level with an LDL of 160. Anytime, if you get a LDL anytime, especially on statins, but anytime of 180 or above, you're very likely to have what's called familial hypercholesterolemia. The reality is about 1 in 200 people have that. And the genetics are, there are about 2,000 at this point discovered and defined SNPs, or genetic variations, that cause this problem. About 98, 99% of them are problems that cause dysfunction in our liver's ability to burn the LDL. the cholesterol in the LDL, so it keeps piling up. The other thing, a related question was ApoA1 or APO. No, she's asking about ApoB. So as you remember, the cholesterol in HDL and the cholesterol in LDL, for the most part, is the same. So why do we call these things different particles? While you were talking, I started to go in and try to find a slide which shows an image, but I'm not going to be able to do that. The bottom line is the difference between HDL and LDL, besides size and density, is the protein that forms it. The protein that forms HDL, whether it's large HDL or small HDL, is ApoA1. The protein that forms LDL, whether it's small dense LDL, small LDL, large fluffy LDL, that protein is ApoB. So it was a great question, Gail, 716. Thank you so much for asking it. Let's run through some others. We've as you and I discussed, Chuck, we might need to have you back to tell a little bit more about the bicuspid valve and some of those other things.
Happy to, yeah.
Kirk Wallach, Randy Halverson, watch Ivar Cummins. It's not always nothing, but usually LDL going high. Check out Dave Feldman. Dave Feldman, it talks about this lean mass hyperresponder. A lean mass hyperresponder is somebody whose LDL tends to stay within normal ranges, and then until they go on a low carb diet, then the LDL starts shooting way up. Dave Feldman, by the way, will say that FH folks are not lean mass hyperresponders. I think the problem, I would disagree, because I've got a lot of that in my patients, and I see significant overlap. I think maybe the problem is it's not 100% overlap. And I think the problem might be, like we said, there's about 2,000 different variations of FH. Hoverson, I'm slim, 5'3", 113. Well, you're doing a lot already to take care of yourself. You and you're probably an athlete at some point. You get good ketones at the beginning, but now your ketones stay close to the 0.5. Any comments before I move on? Unless you fast. It sounds like these guys are having a conversation. Zero proof that high HDL alone is causal or increases your risk. Not sure where he got that. Neither one of us would say that. In fact, high HDL tends to be protective. In fact, there's only one situation where high HDL may be a problem, and that's where you see HDLs like 110, 120. In those cases, it appears that there is a syndrome, there is a condition where you have ineffective HDL, and your body continues to make more and more of it. But that's really uncommon to the extent of being pretty rare. I do have 18.6 eating for the most part. I bet your LDL to trigs is nice. Ketones. Let me see what else we have here. Are you able to see the comments on your side, Chuck?
Yes, I can see them.
It looks like Kirk and
Randy pull them up on the screen. I can see them as you're pulling them up.
Oh, okay. Looks like Kirk and Randy are having a conversation. I'm trying to see if there's anything else we need to respond to. And Sampson, I brought all my Framingham risk factors under control. PCSK9 is very expensive, isn't it? Any questions about, or any comments about expense on your side, Chuck?
Well, yes, it is expensive. It was very expensive when it first came out. I think it was about $14,000 per year. Now it's more in the range of, I would say, about $6,000 a year, $5,000 to $6,000 per year. And insurance sometimes covers it. If you talk to doctors, it can be tricky to get insurance to cover it. But they are covering it more and more, as I understand it from hearing from doctors. They're covering it more and more. It's just kind of tricky, and if you have to pay out of pocket, it is quite expensive.
It is. And usually the insurance companies will want to see some verification that you do have the genetic test showing FH or significant LP(a) value, or and sometimes both, but or that you've tried statins, because most of the folks, even with FH, that try statins do get a significant improvement in their LDL.
And as far as I'm aware, I believe the FDA has not approved it. If you're just targeting LP(a) alone, I do not believe the FDA has approved PCSK9 inhibitor. They want to. It's basically approved to target FH.
Right. And
like you said, when statins aren't working, and then LP(a) is a nice side effect. But it's you may get even more benefit in terms of lowering hazard ratio from the lowering of LP(a). Yep.
So, EZ, I want to get a thorough heart check. Where do you go? We do that for a living, EZ. Call Michelle at 859-721-1414. That's 859-721-1414. OSBC. Magnesium, yeah. Almost all of us are deficient of magnesium, and yes, we all should be supplementing magnesium. Is Repatha just for the combo of high cholesterol and high? Well, we've talked about that. We've covered it. Heart attack 10 years prior and have been studying since. Low fat for me. Subsequent gallbladder issues. Focusing on bitter greens and circadian rhythm and sunshine. Have PMT SNP, which affects the consistency. So consistency can be too thick. Heterogeneous for factor V leading. That's a very interesting thing. The first time we discovered factor V, or when we discovered factor V leading is a clotting genetic variation. It affects your clotting and can cause a slight but significant increase in clotting. I've got a few of those patients. And so therefore it's a heart attack risk. So again, D, similar to LP(a), similar to the other things that we see, heart attack and stroke are really a risk, multiple risk factors piling on you type of thing. And first and foremost, you want to make sure that you don't also have LP(a) or FH or some of these other problems. Thank you for sharing that. Lumbokinase, nattokinase. I've done that. From the lumbokinase, nattokinase, both appear, they're sort of like the vitamin C thing. The logic behind those is great. However, when you actually start dealing with looking at the science, looking at the evidence, not quite as good as we would hope. At least none that I've seen. I'd love to be corrected on it, and I'm sure I will be. Steve Mitchum, I have FH. My blood pressure and sugar are fine when I'm lean, but when I gain even a little weight, they both skyrocket. That's a great comment to cap the day off. It's like a general theme. If it's one, it tends to be another and another and another, and it starts dogpiling on our heart and making, or our vessels, our arteries, and making it very hard for them. So again, we've had some tech challenges again today. We're going to continue to work on those, clean those up. Chuck, I can't tell you again how much I appreciate you showing up. We only scratched the surface on several parts of your story, even though we've been going for over an hour now. Thank you again.
My pleasure. And if you want to have me back at some point in the future, I'd be happy to join you again.
We will do that. Thanks.
Thank you, Dr. Brewer.
Bye-bye.
Bye-bye.